Hello, everyone. Welcome back from lunch. I hope this is a rousing presentation to wake you from your post-lunch slumber. My name is Nessa Kenny, and I focus on displacement and peace at Innovations for Poverty Action. And we're really lucky to have funded much of the research through the UK Foreign Commonwealth and Development Office and the IKEA Foundation that's being presented over these few days. And so that's really exciting for us. Today, we are really lucky, and it's my pleasure to moderate a panel focused on the health and gender dimensions of forced displacement. And I think that this dovetails really nicely with a couple of things that we've heard already today. One is sort of what Tony Verheyen said about sort of the human experience of displacement. And the second is about all of the evidence gaps that exist around, in particular, I think IDPs and gender. And so I won't take up much more of your time, but I'll do very brief introductions of the presenters that we have today. We're really lucky to have three folks that are incredibly immersed in these topics. To begin, Sandra Rozo is a senior economist at the World Bank, and she will present her study on the impacts of regularization programs on the fertility of forced migrants from Venezuela and Colombia. Laura Muñoz Blanco is an assistant professor at the University of Exeter Business School, and she is presenting her research on the impacts of IDP inflows on host communities' polio incidents in Fatah in Pakistan. And finally, Murat Kirdar is professor of economics at Boğaziçi University, and he will present his research on the impacts of the Syrian civil war and refugee status on the risk of intimate partner violence or among Syrian women refugees and migrants in Jordan. A couple of very brief housekeeping notes. We're going to keep the presentations to 20 minutes instead of 25 because we are running a little bit over. So a brief reminder to the presenters. I will be keeping time and will potentially tell you if you're running over. I need to remind myself of this because I just spoke too quickly, but we've been asked for purposes of simultaneous translation to speak a little bit slower. And we will take Q&A not after each presentation, but instead at the end, as was done in the first session, just being mindful of time. With that, I'm just going to hand it over to Sandra.
Oh, hello. Thank you. Such a pleasure to be here presenting. Thank you, Aisha and team, for organizing such a wonderful conference. So today I will present a broad overview of a research agenda that I have been working on the last 8 years with a focus on fertility and health impact. So this corresponds to the impact evaluation that we have been running, trying to understand the effects of a very large regularization program that the Colombian government implemented. So let me begin the presentation. Oh, I don't think this is working. Here we go. Here we go. With two sterilized facts. So the first one is that the number of refugees has more than doubled in the last 20 years, and this is something that we have been discussing. And the prospects for the future are not particularly positive considering the heightened climate change risks and more conflicts emerging every day. The second sterilized fact that I would like to share with you today is that the majority of the forced displaced populations, including refugees, are actually housed in the global south. So here you can see the distribution of that population, and you can see how most of the countries, the darker the color is, the more, let's say, intense of these flows in the world. Most of these are actually housed in Asia, Latin America, and of course, Africa. So now let me zoom into migration in Latin America. So immigration in Latin America has also increased dramatically due to forcibly displaced populations. And so after, let's say, 2015, with the initiation or the beginning of the Venezuelan crisis, we see an uptick in immigration in the region. So here the very dark blue line is showing you the trends for the whole region. So here's Latin America, and you can see this is kind of mapping all the migration flows from one country to the other. So let's see if the laser is working. So in the upper corner is Venezuela, where like all the inflows are beginning, and you can see how most of the flows are actually coming from that country. So if we were to think about all the immigration flows in the region, we will have approximately 15 million people moving across countries, but of those 7.7 million correspond to the Venezuelan crisis. So this is a huge shock to the region, and it's also affecting the United States and Europe. There's a lot of migrants flowing from this crisis. So most of the Venezuelan refugees are actually hosted in 3 countries. The main one is Colombia. So you can see here on your right, the Venezuelan migrants for Colombia, which is the black color, the let's say blue dark color. By 2022, there were approximately 2.48 million refugees, Venezuelan forcibly displaced populations in Colombia. And if you want to think about the share of the population, you can see the other graph on the graph, we can see that it represents approximately 4.8 of the population of Colombia. So this is a very large shock. We're not talking about trivial shocks. This is something very, very sizable for the country. Despite that, Colombia has chosen to do an incredible experiment, which is to be incredibly generous with this population. So because of that, we decided we wanted to study this case and see what have been the effects in many dimensions. So we're going to be talking about regularization programs, but I haven't really told you what they are. So regularization programs are going to be temporary programs that are mostly enacted or approved through executive decisions or decrees, and they are going to give, for a temporary period, migrants or forcibly displaced populations access to state services, financial services, and work permits. So comprehensive, basically they are integrated into the social network, social protection network. They can work, they already are free to move in this region. The only thing they cannot do is vote. So the region has implemented 92 of these programs, and there's 18 countries that have done this, and the leader actually doing this, let's say in the bigger size, is Colombia, and a lot of countries followed Colombia after this initiative passed. And most of them were enacted after 2015 because of the Venezuelan crisis. So actually, this has been a very successful research agenda in partnership with the IDB, the World Bank, that has actually resulted in this policy being amplified in Colombia and applied in other countries of the region. So here are all the regularization programs that we know of in the world. So here you can see how the majority of them are actually hosted in Latin America or being implemented there. But there are other countries that have regularization programs like Italy, Spain, the United States, and Canada. We were not able to find any in Africa, so maybe this is a good, let's say, alternative to think for this region. So the objective of this presentation is going to give you a broad overview of this large research agenda that we have been implementing surrounding the impacts of this program. I'm going to focus on the well-being impacts on migrants with a focus on fertility and health, and then talk a little bit very quickly about the effects on local communities. Later today, my co-author is going to be talking about the political effects of this program. So the program in Colombia was implemented in 2018. It's known as the PEP program. It stands for Permiso Especial de Permanencia. And it was implemented in 2 steps. The first step was a census called RAMB, Registro Administrativo de Migrantes Venezolanos. And this was just a mere statistical exercise. It was collected between April and June of 2018. And it was just advertised as an exercise to know or measure the number of undocumented migrants that were in Colombia. After this census closed, the government announced that anyone registered in that census was going to be granted the opportunity to apply for the regularization program. But migrants didn't know beforehand. And then the government opened registration. The registration was open between August and October 2018. And approximately 500,000 people registered for the census, and 60% of them applied for this program. The program was very generous, as I explained earlier. It gives migrants 2 years of regularization, full access to social protection services, a work permit, and also access to financial services. because I would like to think of this research agenda and the efforts of the World Bank and the IDB, this was a good example of a great partnership. The government decided to expand this program in 2021, not only to these 500,000 migrants, but also all the migrants that arrived before 2021, which correspond to 1.8 million people. It was extended not for 2 years, but for 10 years, and now it includes the same benefits. So let's say a very successful experiment. So the PEP, the smaller program that was implemented in 2018, has a lot of elements that facilitate the very nice evaluation and very clear evaluation of the program. So one of them is that it was not advertised, so the migrants didn't know this was going to happen. And so we didn't have any anticipatory effects, for example, of people moving in because they thought that this was going to happen in Colombia. So what we're going to do is collect data on the migrants that were in the country between 2017 and 2018 and actually leverage the discontinuity in their arrival to Colombia to measure the effects of the program. So here are a couple of quotes from focus groups that we did in Colombia. I wanted to actually illustrate we went and talked to them before when we were designing the surveys. So one of them says, I signed up, my friends signed up too, and we left. We kept selling water because we didn't know how big it was going to be to have a work permit. We didn't give it much importance. So originally the refugees weren't even expecting this to be this powerful and important for their lives. And another person says here, showing evidence that they didn't know what this was going to be useful. Let me go back. So she says, we were registered in the census and they counted us, but we didn't really know what this was for. They told us that it was a socioeconomic census for Venezuelan migrants to know how many of them were living in Colombia. And then later on, they figured they could be eligible for this program. So here is the timeline in the next slide of the program implementation. So our sample is going to be collecting data on individuals that arrived between 2017 and 2019. The program, the census that collected data on undocumented migrants was collected between April and June of 2018, and the program was announced subsequently in July. Then the government opened registration between August and December the same year. Later on, in 2020 and 2021, we went to the field and collected 2 surveys. They are panel surveys following the same individuals in time. So how do we evaluate the program? Generally speaking, is we use what we call in research a regression discontinuity design. So because only those who were registered in the census were eligible for the program, we can have, let's say, an artificial change in the probability of applying to the program based on when the census closed. In particular, anyone who arrived to Colombia before the RAM closed has a higher likelihood of applying because they could be in the census, right? And anyone who arrived later doesn't have any probability of being, or are very low, because they couldn't even be registered. So we're going to use that artificial discontinuity created by the date of arrival and the announcement of this program to have a treatment and control group. And if they are sufficiently close to this date, their socioeconomic characteristics might not be determining the effect of the program. So we have a clean evaluation of the effects of the program. So we collected a sample, a survey that was representative of undocumented migrants and documented migrants living in Colombia that arrived between 2017 and 2018. It's a household survey done through the phone. It was actually planned to be done in person, but COVID-19 arrived, so we had to do it on the phone. The most challenging survey I have ever implemented, because we were trying to find undocumented migrants on the phone. So imagine that. Hello, sir, are you an undocumented migrant? So we learned quite a bit of things during this paper, and I have another piece of research kind of highlighting those lessons of what not to do, which is what we learned very quickly. And then we collected a sample for approximately 3,400 households, the first wave, and then we lost some of them, and we were able to recontact only 2,300 households. The attrition rate is not random, and so we had to correct our estimates and conclusions based on that attrition rate. So here is the Colombia and where we collected sample, and so the people who are eligible for the program, for the PEP, their listing or the sample comes from the government. The government actually shared with us the census, so we just found a random sample for those. And for those who were undocumented, this comes from a random sample of a large listing, the largest listing we could make based on referrals from migrants and referrals from migrant organizations. So we measure the impacts of the PEP program on welfare and labor markets, on integration and perceptions, and on health outcomes. Here are the effects on well-being for migrants. So the PEP improved dramatically the welfare and well-being of forcibly displaced migrants in Colombia. So it improved their health status. This includes physical health and mental health. It improved their consumption per capita, their income per capita, and then we kind of combine these variables into an index, and we show that actually this is just saying that the well-being of migrants is improving dramatically. The PEP also increased state services. And this is something not surprising. We're just granting them access, so they actually applied for those things. The question is why this is not higher, and we're going to talk a little bit about that in a second. So more transfers from the government, more financial products, more subsidized health regime, and also more applications to the CISBEN, which is the proximine test that measures or through which programs are targeted. Are you guys okay with some people are touching their ears? Are you okay? Okay. I just want to be sure that you can hear me well. And there, surprisingly, we did find some positive effects, but it's suggestive evidence on labor outcomes for well-being for the refugees, for the forced displaced Venezuelans. Very imprecise, and it points to more formalization rates of approximately 10 percentage points. Okay. So the next exercise that we did was to try to understand. So we actually observed these huge positive effects in well-being. Is this mostly mediated through service access or labor market improvement? So we tried to do an exercise in which we clean the variation in the outcomes according to the service access and labor improvement, labor outcome improvement. And basically what you see, the first, let's say, coefficient that you see in the figure is showing you the normal effect without cleaning anything. The second is showing you the effect when we clean the variation coming from service access, and the third one when we clean the variation coming from labor market improvements. Basically, the conclusion from this analysis is that services is explaining a very important part of the effects of well-being, because when we actually clean this variation, the effects are no longer significant, statistically significant. So we also did an evaluation of the fiscal effects of the program. So that's going to be, it's a very simple exercise, a very simple accounting exercise in which we took into account the costs created by the program in public programs and services and social assistance, the revenue coming from consumption taxes and payroll taxes, and we're going to exclude everything else. So there is a lot more things that are happening. We're not going to take them into account. So I want you to focus on the first two columns on this figure, and basically they compare a household without PEP, without the program, completely undocumented, and one that actually has the PEP but never formalized. So the worst case scenario. They only use the state services, but they never improve their formalization. They don't pay payroll taxes. So the negative is suggesting the cost for the government. So the larger the negative effect, there's a higher cost for the government. So what I'm showing you here is that it is less expensive for the government to actually formalize, give this permit to refugees. And this is because they pay more consumption taxes, because they increase their income, and also because the services that they're using are less expensive. They are using more preventive services and less emergency services, concerning health. So also the government saved money. In terms of fertility decisions, we observed that it declined. Everyone who was beneficiary of this program showed reduced fertility rates. And here we do a placebo test in which we test whether those individuals that were born before the program was implemented, they should see no change. We actually see no change for those ages, but we only see reductions in the probability of having a kid that is 2, 1 year, or 0 years of age after the program was implemented. So a reduction on fertility. So what about hosting communities? So we do different papers in which we evaluate the effect of this program for hosts, and we see very small effect. Actually, if we increase this regularization 2 times, meaning from 500,000 people to 1.5 million people, so a huge change, formal employment will only be reduced in 0.15%. So very, very small effects, negligible almost, and no changes in monthly wages, hourly wages, or hour work. Okay. So why do we think this is? Everyone is asking us this question. Another thing is we didn't find any changes in crime. Crime was not increased or decreased. Actually, the only thing that happened is Venezuelans reporting more crimes against them, the women specifically, concerning sex abuse and domestic abuse. So why do we don't see any effects of changes in labor market? It could be because it's a short term and maybe the effects take time to materialize. That could be one potential explanation. Another one could be, and we actually find some evidence of this when we talk to migrants, that they are not willing to formalize. And so they are not switching from the informal to the formal sector. They actually told us, a lot of them, this is a possibility because they don't want to pay taxes. They just want to have access to state service. Some of them actually mentioned this. It could be that firms are not willing to hire migrants because they are discriminating them, even if they have a permit. Or it could be that there are positive effects because migrants also consume, and this creates positive effects in the economy, which actually are being translated in this reduction on the effects on positive and negative externalities for Colombian workers. So with this, I more or less wrap a very long agenda. I gave you an overview. Let me just kind of wrap up with the policy discussion, and then I'll stop. So we find that the regularization program in Colombia improved tremendously the lives of migrants, and it maximizes the positive effects of long-term economic growth. So basically accelerates how long these individuals can begin to contribute in these economies. It releases pressures in the informal market. At least they have the choice to jump to the formal sector if they have the possibility. It's not all concentrated in the formal economy. It reduces the fiscal pressures for the government. These crises are not sustainable. Cannot forever think that we're going to be given assistance to these refugees. There's more crises, and they are very long. So the sooner we help them to become self-reliant, the more sustainable this is going to be. And I think it's important that this message comes through to governments. And then there's more to do. One of the things that we learned from this agenda is that despite doing this, let's say the legal framework was not translated very quickly into actual access to services. So for example, there was discrimination from the officers, or they didn't know about the program, and so it took time for them to actually integrate the refugees. Some firms didn't even know what this was. So they want to find a job, for example, or open a bank account with these permits, and banks were like, what is this? I don't know what this is. Is this really something that we can use? So we can do a lot to reduce those things, like, for example, train our public servants to be more inclusive and not discriminate migrants, and also inform them about the program. And then I think the very last thing that I would like to say today is that we still need to work on creating jobs, because at the end, even if we give them a job permit, but if there are no jobs to access in the first place, then that's
Thank you so much, Sandra. In the interest of time, well, I take the opportunity to say thank you to the organizers for putting all together. I'm delighted to be here.
Thank you, Sandra, for the informative discussion and presentation, and for the nice introduction as well. Okay, so what I'm going to present today is a work in progress that is on the spread of diseases, vaccine delivery, and forced displacement, in particular about internal displacement. So let me start. Let me try that works. Okay, yes. So let me start by motivated. So after COVID-19, we are all aware that the spread of diseases comes together with economic, political, and social consequences. And intuitively, the quick movement of population and the low vaccination levels might lead to a quick spread of diseases. So intuitively, having said that, given the current situation that the numbers of refugees and IDPs keep increasing over time, there are new challenges that we need to face. So many of these population, refugees and IDPs, they come from conflict-affected regions where many of the health services has been disrupted by the conflict and the mass displacement. On top of that, they face important barriers connected with mistrust in the government, security concern, and lack of information in their local languages. So vaccinating refugees and IDPs is an important component for preventing outbreaks. In particular, targeting IDPs, given that they don't cross internationally recognized border, and is sometimes an important challenge to vaccinate them. So in this project, what we try to do is try to evaluate a policy on how to effectively, or how effective a vaccination policy targets hard to reach population, in particular IDPs. So to answer this question, we start by tackling a basic question that has been already discussed in the literature, that is, what impacts do IDP inflow have on the number of new polio cases in the communities where IDPs end up migrating to? Okay, so to answer this question, we are going to look at the internal displacement crisis from the Pakistani region of FATA, that is, it stands for the federally administered tribal areas. This is an internal displacement crisis that started in 2008. From the methodology point of view, it's going to be a classic difference in difference. Let me clarify what does it mean. What we are going to do, we are going to compare new polio cases using two sources of variation. So we are going to compare new polio cases in host districts before and after the IDP crisis started in 2008. And then we are going to add another source of variation, that is the distance from the origin of the migration. Okay? One of the contributions of this paper, as I mentioned early on, is evaluating one innovative program that is vaccinating IDPs during their migration trajectory. So it means during the migration route. What does it mean? It could be targeting IDPs, not in the origin, not in the destination. So it could be before arriving to their host communities. Okay? I'm going to give you more details in a few slides. What do we find? Just some preview. So in line with the literature, looking at the effects of the arrival of refugees in host destinations, we observed that an increase in IDP inflow led to an increase in the new polio cases in host communities. The main mechanism behind seems to be the unequal distribution of vaccines between natives and IDP children. But when we incorporate the policy that was designed and implemented in 2018, 4 years after the beginning of the IDP crisis, what do we observe? We observe first a mitigation effect in terms of IDPs increasing their likelihood of being vaccinated, and a decrease in the number of polio cases. Let me highlight that this is not an isolated effect. Having vaccinated children that are healthier children come together with an important welfare implication, not only for IDPs, but also for natives, right? We could think about education outcomes, but also long-term labor outcomes. Okay, So let me give you an overview on the setting. Okay, as I mentioned, this is a conflict-driven migration that happened in Pakistan. In particular, the origin is FATA, that's how I will call the federally administered tribal areas. So what is FATA? FATA is bordering Afghanistan on the north and other 3 provinces within Afghanistan. Within Pakistan. So this is one of the poorest regions in the country, is a rural region, and on top of that is the core of the Pashto land. This to say that is part of an historical and pre-colonial ethnic group that is Pashtunistan. Okay, and this is going to be important for answering our question. But let me tell you a little bit about the conflict. So the conflict started in 2001 after the terrorist attack in the US. So since then, FATA has been the scenario of an important military offensive implemented by the Pakistani government and the US. And why? It is just a military offensive against the Taliban under the suspect that bin Laden was hiding in the region. Okay? But the conflict changed over time, and this is what I'm going to highlight in this slide. So what I'm plotting here is the number of drones in over time, so every year, and the number of drones is going to be our proxy for capturing the conflict over time and across space. Okay, so 99% of the drones strike or hit in FATA. And what we can see in the blue line is the changes in the new IDPs every year, okay? So when we look at the changes over time, we observe an important jump in the intensity of the conflict from 2007 and 2008. And these jumps comes together with a jump and at the beginning of the IDP crisis, okay? And this is going to be our main identification, okay? Or our main tool to answer our question. Just to give you some numbers, so from 2008 until today, 45 and 60% of the FATA population flee from the region, and it's an important crisis, okay? But where do they move? So this is an internal displacement crisis. So only 1% migrated out of the country. Most of them are IDPs. So they migrated to relatively close areas surrounding the FATA region, and 90%, according with the data from the UNHCR, moved into host communities. So they were not hosted by IDP camps, okay? And this is going to be important for our outcomes. Why? Because you can imagine in host communities that are overcrowded with poor health conditions, polio, that is a highly infectious disease, can be easily transmitted. And how polio is transmitted is through an easy contact. So you can imagine being in contact with an infected person, droplets from his sneeze, or just, or in contact with the stool. Okay. So what about the symptoms? So 1 out of 4 infected children or persons, right? I mean, they suffer major symptoms. So we could think about problems in breathing and as well partial or full paralysis, okay? How is the situation in Pakistan? So Pakistan is 1 out of the 2, together with Afghanistan, where polio hasn't been eradicated, okay? So we can observe there are changes over time, okay? So at the end of the 20th century, there were roughly 1,000 cases. And then in 2005, there were only 28 cases. When we observe, and when we look at the data, we can observe that after the beginning of the IDP crisis, so after December 2007, we can observe 100 cases per year, okay? But polio, there's no cure for polio. It can only be prevented through vaccines, Okay, so let me give you an overview of how is the vaccine situation in Pakistan. So Pakistan follows the vaccination calendar recommended by the World Health Organization, and the first vaccine is an oral vaccine and is implemented right after birth. Okay, and the standard and the most common vaccination strategy, as you can see on this picture, is when health workers and health volunteers, they target or they identify children under 5 going door by door, okay, and is free of charge, okay? So these are the picture, and how the vaccines or the immunization level has changed over time. We can observe, looking at the data from the demographic health survey in 2006, there were 50% of the children were vaccinated, and however, 10 years after, in 2017, there were 68%, okay? So there were a considerable increase, okay? But how we are going to answer our question? So we are going to pull together 4 main data sources. First, the outcome, that is the new polio cases. This is at the district level, and we are extremely grateful that the Global Polio Eradication Initiative provided the data. So this is just an example of what we mentioned early on in the policy discussion. We're having data and working hand in hand with policymakers is vital for conducting this kind of research. Okay, so these data are at the month level, and they are from 2001 to 2022. Then we have individual level data on health-seeking behavior and vaccination information on top of migration information from the demographic health survey. We have 4 waves so far, and yes, 2 before 2008 and 2 afterwards. Then for capturing the changes of conflicts over time, we use the data provided by New America, that is the localized location on drones, and this is from 2004 to 2022. And then we use a standard and reliable data source. So thank you. I was discussing with a UNHCR colleague this morning. So we use data on the total and the new IDPs created over time. These data are at the province level, and we have as well some district level information from 2008. Having said that, let me clarify the administrative division of Pakistan. Sorry, I apologize that I haven't mentioned this before. So Pakistan is divided into different provinces, a province into different divisions, and a division into districts. Districts is going to be the unit of analysis for this project. Okay. So how we put together all this data for trying to answer our research question. Let me remind you what is our research question is first looking at the impacts of IDP inflows on the new polio cases created in the host district. How we try to answer this question? We use a difference in difference, so we compare the new polio cases before and after the beginning of the IDP crisis in 2008, and then we compare the variation across district. And how we do so? So we don't have the data at the district level, so then we need to predict the IDP inflow in a given district. And how we do so? We interact the number of IDPs in a given year with the district, with the distance to the FATA border. Okay, and this comes under the assumption, and then we saw as well empirically that the districts that are closer to the FATA border receive higher number of IDPs. Okay, but of course there is a problem here, right? Because the same assumption, the main assumption here is that those districts that are closer and farther away from the FATA border, they should be pretty similar in characteristics such as cultural factors, political or economic characteristics, right? And the only thing that should change is just the intensity of the IDP inflow. So to try to tackle this important empirical challenge, we are going to play around with a concept or a term that I introduced at the beginning, that is the border of the ethnic homeland, that is the Pashtunistan. So we saw empirically, so with using some data, that the characteristics, economic, political, and cultural characteristics do not change across distance, right? So there is no correlation. And this is going to be our sample. It's going to be the district whose territory falls entirely or partially within the Pashtunistan region. Okay? Let me come back to the results. Let me show you the raw data. So what do we observe when we take the data and we just plot them? Okay? So let's look at the first graph that is on the right side of this slide. What we can see is that right after 2007, there is a jump or an increase in the polio cases. Of course, it's very noisy. Okay? But then let's do the same when we split the sample in those districts that are closer and farther away from the FATA, right? So in this case, if we look at the left hand side diagram of this slide, probably you cannot see the colors, but the blue line is those that are closer, so it means they are strictly bordering the FATA borders, and those that are dust gray are the farther. So what we can see is that there is some differences in the number of new polio cases created. Okay? Let's make things a bit more technical. Okay, I'm skipping showing equations, but what I would like to highlight is that we observe that when there is an increase in the IDP inflow, there is an increase in the number of new polio cases. Okay, sorry, I apologize. I'm plotting the same equation, introducing different covariates, but what I would like to bring your attention is the blue coefficient, right? So there is an increase. And this is a sizable increase. There is an increase in the 30% of the mean in our time period. Okay. Great. For the technical levels, I'm happy to discuss afterwards Sandra checks. Okay. But let me continue with the policy evaluation that we believe is the most interesting part. Okay. So what is this policy about? We are going to call it, or it's called, the Permanent Transit Vaccination Program, or PTPs, for the rest of the presentation. It was launched by the Global Polio Eradication Initiative in April 2012, so 4 years after the beginning of the IDP crisis. It targets the highly mobile population. So we could think refugees, nomads, but also IDPs, that this is what we care. So just to give you some example, right? So they established permanent vaccination point in those locations where there were a major population transition, right? So in particular, we connected with the FATA conflict. So we can, there were some permanent vaccination points in major roads, major bridges, some bus stops, train stations, and also on the borders, administrative borders between districts. So this is not refugees, right? So tracing them is a challenge, okay? So who is based in these permanent vaccination points? So the health workers are male workers, belong to the community, they are trained by the Global Polio Eradication Initiative, and they are very familiar with the customs and with the transit seat, okay? And we believe this is very important. Just to give you some numbers, just in 2018, 1.7 million children were vaccinated, okay? How do we evaluate the policy? So in an ideal world, we will have data for the entire country. So thanks to the Global Polio Eradication Initiative, they provide us with this map. So this map is covering the permanent transit point for 6 out of the 39 districts. So we are hoping to get some data, but now they are chasing the polio in Gaza, so they are not, I mean, we need to delay the increase in sample size. So what do we do in this project? So we digitize this map for extracting the location of the permanent transit points, and what we follow is a simple approach. First, we start by counting the number of permanent transit points in our unit of analysis that are districts. And then we can even continue counting the number of permanent transit points in or nearby the location of households. So the demographic health survey have the GPS location of households, so we can implement as well a sort of buffer analysis. What I'm going to present today is the results implementing the simple approach with the number of PTPs. This is a work in progress. Perfect. So what do we find? So first, let me show the results on how is the vaccination, so how IDP inflow affect the vaccination level before the policy, before April 2018. What we can observe is, indeed, there is an increase in the vaccination level, okay? But this increase is driven by natives. So there is an important heterogeneity between natives and IDPs where there is an equal 2 minutes. Okay, thank you. So I are negatively affected. What do we find after the policy? So after the policy, we can observe that indeed the ones that benefit from this policy are the IDPs and not the natives. There are no effects among the natives. Okay. And what about polio cases? So we observe a mitigation effect. Okay, even in a sample of 6 districts, right? So it's not significant at the moment, but in the case of the vaccination, it's a significant effect among IDPs. However, given the restriction in power and sample size, there is not effect. But let me conclude. So what do we find? Why do we observe this effect? And this is part of another project, or try to understand why do we observe this effect. Is because 90% of the IDPs are settled down in communities, so then there is an increase in the access to IDPs, or is because there is an increase in supply, or it could be given that we involve the community and they are familiar with the customs and traditions, there is an increase in institutional trust, or is just playing with the timing. We are vaccinating children before they arrive to host districts, so as a consequence, we are preventing an increase in polio cases. Okay? Sorry. So let me conclude. And there are 2 main takeaways that I'm going to repeat myself. First, there are an important welfare implication. This is not an isolated effect. If we vaccinate children, we are preventing the polio cases, but we are benefiting, we are creating positive effect not only for IDPs, but also for natives, because it leads to an increase in educational outcomes and other welfare outcomes. And this is not only affecting, these findings could go beyond the case of Pakistan. At the moment, new polio cases has increases in countries and regions where they were polio-free for the last decade. So we could think Malawi, Mozambique, and Gaza. And it's not only about polio. I mean, we could think about implementing this sort of policies in for other diseases. Thank you so much.
Thank you so much, Laura. Really appreciate it. Without further ado, I'm going to hand it to Murat Kirdar, who is a professor of economics at Boğaziçi University, who is joining us online. Murat, over to you.
Okay. Thank you for the organizers for inviting me. This is joint work with my PhD student who she has recently finished, and we are looking at the effects of Syrian civil war and forced migration on IPV among Syrian refugee women in Jordan. So why do we care about this topic? First of all, IPV is more common than you might think. The World Health Organization reports that nearly 27% of women aged 15 to 49 experience IPV at some point in their lifetime. And there is extensive literature that shows adverse links from IPV to mental physical, sexual, and reproductive health. And the economic costs of IPV have been shown to be really large. The literature has shown associations between conflict and IPV, and as well as between refugee status and IPV. But most of these studies are based on either small-scale studies or they are simply show associations between IPV and these conflict and refugee status. Our study is different in the sense that we are using a nationally representative data. And the key piece of data in our study is we know information about the exact timing of the first episode of physical violence. Okay, so we can track women from the time of their marriage until the first episode of physical violence. So through this tracking, we know whether the woman is in Syria before the war, Syria after the war, or in Jordan as a refugee. So we can really connect their position to IPV outcomes. Therefore, also accounting for unobserved heterogeneity, we claim to come much closer to estimating the causal effect. And another key feature of our data set, of our study, is that we delve into the mechanisms of the observed effect of civil war and refugee status on IPV, unlike the previous studies. In particular, we'll look at the effect of economic outcomes. We look at the effect of social networks. That's another important piece of our study, because another key piece of data is that we know the GPS locations of all women in the data set. So we can really generate networks based on distance using this data. And finally, we also look into marriage as a mechanism in the change in the IPV outcomes. A quick background information: many of you are familiar with the Syrian refugee crisis, and one of the three main destination countries is Jordan. And Jordan is, this setting is important because Jordan has the second highest share of refugees in the world. And most of these refugees live in urban areas. A small fraction live in camps at this point. And this is a very young population. Almost half of them are under the age of 18, and they are poor. So the data that we use is the 2018 Jordan Population and Family Health Survey. This is very similar to the DHS that is implemented in several countries. It's representative of the women in Jordan, as well as Syrian women, as well as the native women. And we use the domestic violence module, but we particularly focus on physical violence because the timing of the first episode information is available only for physical violence. But we can see from the data set that physical violence is also highly correlated with other types of violence that women may face, even though we just see physical violence. We have 681 Syrian ever married women in between the ages 15 and 49. And we use two complementary data sets to get information about pre-war Syria. These are the 2009 Syrian Family Health Survey and the 2006 Syria mix. So, as I told you, the key variable is the timing of the first physical IPV event in years after marriage. So basically what we use a duration analysis. So in the duration analysis, the waiting time concept is time after marriage. So once the woman gets married, this clock starts ticking. The clock keeps ticking until the first event of physical violence. If there's no event of physical violence, if the data is right-centered, we go up to the age that we see the woman in the survey. Just to understand this data format better, let's look at this sample woman who is 32 at the survey age, but she got married at age 25, and she was exposed to physical violence at age 30 for the first time in 2013. So the data is in this format. The clock starts ticking at age 25. Look at age column. The clock starts ticking at age 25, and it goes until age 30. Until, look at the exposed column, until she is exposed. Okay, so we follow her from age 25 to 30 over the years 2010 to 15. And because we know the year, we know whether she is in pre-war Syria, post-war Syria, which is after 2011, and because we know her arrival year, we know whether she is already in Jordan as a refugee. Okay, so this post-war Syria dummies and in Jordan dummies are going to be our key variables of interest. And the specification we estimate is a discrete time hazard model. And we use logit estimation. And here, HD is the hazard rate. For the non-technical audience, hazard rate is essentially the probability of observing IPV for the first time at time t, conditional on having not observed it until that age. Baseline hazard is shown by this BT. It's basically, it shows the propensity of facing IPV at time t. And x's are the covariates. Basically, these x's, you can think of these x's as shifting the baseline hazard up and down. Basically, they increase or decrease the risk of facing IPV. In particular, more specifically, the specification is in the equation 2 form. These are basically the baseline hazards. These are years since marriage. Basically, as I told you, the time clock starts ticking at the time of marriage. So like D is a dummy for the first year, for the second year, for the third year, for the fourth year. We group these. We group these because of estimation purposes. So it could be 1 to 2 years, 3 to 4 years, and so forth. So post-war Syria, whether the woman is in pre-war Syria, post-war Syria, or in Jordan are key variables of interest. Z is the other control variables. As I told you, we account for permanent unobserved characteristics of the woman. So we may be missing some unobserved characteristics of the couple. Some couples, even after controlling for these covariates, may be more prone to IPV than other couples. So we basically use a parametric approach to account for permanent unobserved characteristics. This is important because it could cause extra duration dependence in our data. As couples with higher IPV propensity leave the sample early, the sample would include more and more couples with lower propensity for IPV. So essentially this accounts for the permanent unobserved characteristics to account for that. This is also important because a seminal paper by Lancaster earlier in 1990 shows that if we do not account for unobserved heterogeneity, the effects of these key variables of interest, beta 1 and beta 2, would be attenuated towards 0. So this is pure data, descriptive statistics. Here, on the x-axis, it's years after marriage. So the clock starts ticking. And on the vertical axis, it's the hazard rate. As expected, the hazard rate of IPV is higher in the first years. Observing it for the first time is higher in the first years, and it decreases over time, as most hazard functions are. But here the critical thing is, as you see, the hazard rates in Jordan, the green line, and the hazard rate in post-war Syria, the red line, is higher than the hazard rate in pre-war Syria. So the data, the pure data, suggests an elevation of the hazard rates both due to the conflict and due to refugee status. So this is the estimation results under different specifications. So here we're going to the difference is that the odd number columns do not account for unobserved heterogeneity. The even number columns accounts for it. First and second columns have piecewise constant baseline hazard. 3 to 6 have cubic polynomials. And 5 and 6, fifth and sixth columns are different from 3 and 4 in the way that baseline hazard is interacted with marriage age. Here, marriage age becomes a state variable, and the hazard rate might differ based on your marriage age. Therefore, we account for it, but empirically it turns out to be not so important. So because this is a logit estimation, let's focus on the marginal effects. And especially our focus is column 2, which accounts for unobserved heterogeneity. We find that, in fact, both the civil war, the hazard rate is higher in post-war Syria than in pre-war Syria, and the hazard rate is higher in Jordan than in pre-war Syria. So the hazard rate is 2.4 percentage points higher in under refugee status than in pre-war Syria. Okay, so both events causes an elevation of the hazard rates. So one might be worried about a sample selection issue because the civil war and refugee status may not only change IPV rates, but they may also change the marriage hazard rates. So the woman in our sample might change. To basically eliminate this kind of a compositional change, what we do in column 1 is that we restrict the sample to women who were already married before the civil war began. Okay, so there's no change in the sample due to a change in marriage patterns. Even after that restriction, despite smaller sample size, we see very similar coefficient estimates, but as expected, statistical significance is lower. It's just marginally statistically insignificant. Another concern could be recall bias, because we get the information about the first IPV event from the current survey date. So women answer questions about time in the past. So we make restrictions about the based on age and about years after marriage. And even after we make those restrictions, basically reducing the recall bias, we see that our results are robust. Another question is that, okay, both events, the civil war and refugee status, increase the IPV propensity. But how do they change by years after marriage? So in its different specification, we interact in Jordan dummy variable with years after marriage and post-war Syria dummy variable with years after marriage. What we see in this case is that essentially we estimate the effects by years after marriage in this case. The first one shows the effect of refugee conditional on years after marriage. Okay, and we see that refugee status has a bigger impact in the first years after marriage, and similarly the war has a bigger impact in the first years after marriage. After basically 6-7 years for refugee status, and after 5 years for the civil war, the effects go away. And another similar question is, how does it change by time in Jordan? So this interacts with years in Jordan, and we see that refugee status especially matters in the first years as a refugee, and the elevation of the IPV risk goes down as time increases in Jordan. Okay. So, given these findings, like how do we make sense of these increases in IPV? So we essentially come up with three different explanations. One is that, as the literature shows, economic distress can contribute to IPV. And using data, as I told you, from pre-war Syria, we compare the economic status of Syrian refugees in pre-war Syria and under refugee status. So what we see is that their employment levels are much lower and their asset holdings are also lower. In fact, we see an important deterioration in their economic status. And if we compare the refugee wealth distribution with the native distribution in Syria, we see that refugees are doing much worse. So obviously this doesn't prove it, but as a supportive evidence, we do the following. So we split the refugee sample by the husband's educational attainment. Okay, on the left-hand side, we have husbands with low educational attainment. On the right-hand side, we have husbands with high education. And we look at the loss in their employment, okay, after arrival in Jordan. We see that husbands with low educational attainment face a much higher loss in employment after arriving in Jordan, okay? Whereas more educated husbands face less losses, okay? So the economic stress is, we know from this that the economic stress is higher for husbands with low educational attainment. And when we do the same analysis on IPV outcomes by husbands' educational attainment, in fact, we see that the rise in IPV outcomes comes from marriages in which the husbands have low education. In a sense, in families where the economic loss is higher, the rise in IPV is also higher, okay? So this provides stronger evidence on the relationship between economic stress and IPV for this group of refugees. So another explanation that is put forward in the literature is that female refugees lose their social networks after moving into a new country. The previous literature generally measures this using whether the woman has family close by, whether they see their family. But this may be due to simultaneity, because whether a woman sees their family or friends may also depend on the IPV outcome. Okay, or it may stand for personality traits, like a more extrovert woman would be more likely to see them and less likely to face IPV. What we do in this study is that instead we use their location. And from the GPS data, we know where the other Syrian women live in Jordan. Okay, so we can essentially construct measures of social networks and their proximity. And when we put those in the same regression, okay, we interact in Jordan dummy with the Syrian household density in a 2-kilometer radius of the woman and in a 5-kilometer radius of the woman. And as we see, when there's a higher Syrian density in the particular woman's neighborhood, the rise in IPV is lower. Okay, so this suggests that social networks in fact provide a caution against a rise in IPV. And another issue could be, as I told you, marriage. But as we showed, marriage cannot be the only reason, because when we restrict to women who were already married, the results remain. But still, we check, again using duration analysis, we check how the two events, how the civil war and refugee status change the marriage outcomes of women also in duration analysis, because we know the age at marriage, and we track women from age 12 to the time of the marriage, again using duration analysis in the same way. And using the estimated effects by age, we calculate the mean age of marriage. And we find that the civil war, as a result of the civil war and refugee status, women become more likely to get married at earlier ages. Actually, this is also true for Syrian women in Turkey. We show it in another study. So women become more likely to get married earlier. The average age of marriage goes down, and this is the previous literature shows that the IPV risk increases in early marriages. So our finding of the fall in the age of marriage is consistent in this sense with the rise in IPV. The literature also relates the cousin marriages, polygamy, and age between spouses to IPV. The literature finds that IPV is lower in cousin marriages, whereas it's higher in polygamous marriages, and it's higher when the gaps in education and age are higher between the spouses. So we look at that. We examine whether the rise in marriages is higher for cousin marriages or non-cousin marriages. Okay, we find that the relative increase, the proportional increase, is much higher in non-cousin marriages. Okay, so as I told you that cousin marriages lowers the IPV risk. So the relative rise, the proportional rise, okay, the disproportionate rise, I should say, in non-cousin marriages is also consistent with the rise in IPV. In contrast, we find a relatively higher increase in non-polygamous marriages, and we find a disproportionate increase in marriages where the age gap and education gap is smaller. Okay, so then the patterns in the polygamous marriages and age education gaps would not contribute to the rise in IPV. So in a sense, in terms of marriage patterns, the fall in the age of marriage and the fall in cousin marriages are consistent with the rise in IPV. So to conclude, we find that civil war and refugee status for Syrian refugee women in Jordan increase the risk of IPV, and the most substantial impact is realized in the early years of marriage. And we also find that the effect, the refugee effect, decreases over time in Jordan. And we come up with three explanations. One is economic distress, one is the loss of social networks, and one is the rise of early marriage and the fall in cousin marriages. Okay, essentially that's all I will say. Thank you very much.
Thank you very much, Murat. And thank you to all of the presenters for those wonderful presentations. I'm now going to hand it over to the audience, both in person and online, to see if there are any questions. Perhaps we'll take 3 at a time and then pass them to the panel, and then maybe we'll have time to do that twice. We'll see. Please, at the back.
Okay, good afternoon and thank you for the presentation. My name is Basiru Shitu and I'm the Dean of the African School of Economics. My question is for Sandra, and in her presentation she used both the word migrant and refugees. And I wonder if the result combine Yes, I wonder if the result combine both migrant and refugees, or if the term were used without distinction. Thank you.
Thank you. Other questions, including from online, Domenico? Are there any? Aziz, please go ahead.
Thank you so much. Hello, everyone. My name is Adam Abdulaziz. I'm a evaluation and policy manager at IPA. I will take my policy hat and ask my following questions. And my question will be toward Sandra. And then thank you so much and really appreciate the result. My first question will be to know how we could apply the evidence that you shared in some context. If I take the context of West African countries, for instance, where we are working in a union where there is no work permit for people, for instance. And I know that the idea with the work permit that the government gives to displaced people is to say that you could be autonomous to work and take it yourself. How in our context, for instance, the ministry or public servant could send this signal so that it could also mimic the result of the work permit. The second question will be to know if in your studies you were able to see characteristics of hosting population and the displaced people. I'm asking that because same thing here, you may tend to see that the displaced people tend to have similar characteristics than the hosting communities. And in that context, if there is no complementarity and then people have to work, that will also increase the tension if the labor market already have highly stressed. Then in this context, how you think, do you have results that show if the hosting communities is quite similar or different to the hosting unit, for instance? That could be my question. Thank you so much.
Thank you. Other questions? Is there a third? Otherwise, I'll hand it over to Sandra now. Colette.
A question for Laura. Thank you so much for your talk. I wanted to ask about the mobile programs and how they related to other forms of vaccines. Eradicating polio is a huge goal, but of course, I'm sure there's other vaccine priorities. So were others included and just polio was very well documented, or was there a particular focus on polio because of country characteristics? Thank you.
Great. And we will actually perhaps take one more from online. I believe there's one online.
Thank you. It's actually a question from Murat to Sandra. He's asking how you can explain the fall in fertility. Thank you.
Perhaps we'll go to Sandra first.
Thank you. All very good questions. So let me first clarify on the term. I'm sorry that I wasn't very clear. So this is mainly a political decision. So Venezuelan population has been recognized as a forcibly displaced population of interest. In other words, in Latin America and many countries, they are not considered refugees, but this is because legally that would bind countries to certain things, and so certain countries are not willing to give, this recognition. But they are very much considered under the umbrella of UNHCR as a forcibly displaced population. So it is possible. Migration is very great, that there are voluntary migrants, especially initially in the crisis. But towards the end of the crisis, say around 2018, approximately 35% of the population of Venezuela left the country. So for sure, more and more vulnerable people have been leaving. And right now, the country's poverty line is approximately 94%, coming from a 30%. So people don't have food, they don't have medicine, conflict and violence is rampant. So they are very much considered forcibly displaced populations right now. But it is true that in the initial stages of this crisis, some voluntary migrants that are highly educated might have, let's say, flee the country first. So very much forced displaced populations. That's how we define them in the region. But now the term refugees is more loaded in the region. In terms of the dissemination of the program, so there was a huge campaign through the migrant organizations. So when the program began to be implemented, we learned that migrants were very scared to register because they were undocumented. So they were a little bit afraid of being in the radar of the government because they actually kind of say migrated without the proper documentation. So what we learned was that we needed to first work through for example, to even get responses to our surveys, we needed to work through migrants themselves. We had to hire migrant enumerators. The government had to work through migration organizations to get the trust of migrants first and tell them that this was not something to hurt them, and then once that happened, it was possible to then do the surveys and of course, some of them applied to the program. That being said, there is still the issue that probably those that are more trusting were the ones that actually registered for the program. Luckily, they had a second opportunity. In 2021, a larger program was open, and now they knew it was true, that this was not something to hurt them. And so more people applied that time. So dissemination through migrant networks, that's more or less the answer, the simple answer. And then Colombian and Venezuelan populations are more or less similar. So the wave of migration was such that at the beginning of the crisis, around 2013, very highly educated Venezuelan migrants came to Colombia. These were all the entrepreneurs and people that were fleeing because they were afraid of being expropriated from the Venezuelan regime. And they were much more educated than the Colombian population. So they were very welcome in a way. As the crisis became more pronounced, more and more vulnerable people have been arriving. The last wave of migration actually had people walking from Venezuela to Colombia because they didn't even have money to pay for the trip. Super vulnerable population, and those are less educated than the average Colombian. So the recent waves, the larger waves, are much more vulnerable than Colombia, but the initial waves more educated. And then you can also map heterogeneous effects of these different waves, of how people respond to them. In a way, not surprisingly, people are more willing to receive those folks that come with money and are more educated, whereas when more vulnerable populations came in, it became more challenging for folks to accept them because they saw them as substitution and competing for their jobs. But what this case shows, and my colleague is going to be talking about that, is that because we were similar in a way, we were a very close region, like here, like the one that you're mentioning, people thought, let's just help them as long as no more people comes. That's more or less the message that you got from people when you talk to them. If they are here already, let's just let them work. We're not going to be able to maintain them forever. They need to work and make their own way. That's more or less how Colombians talk about this. But as long as this is not pulling more people to the country, that was, I think, the fear that they had. Or this is what you hear when you talk to migrants. And then what was Murat's question? The fertility. What explains the fertility effect? So we actually check for mediating factors, and we see that access to services was the main channel that drove the reduction in fertility, access to family planning. That's what we found.
Thank you, Colette, for the question. So let me start with the question of why this program. So it was implemented in the middle of the crisis, and many other programs have been implemented to target refugees. That is mainly having this mobile vaccination team on the borders, and much of the efforts has been as well targeting children in refugees on IDP camps. This program, it was the first time that the global polio eradication implemented. So it was, I think it was Malawi and first Pakistan and then Malawi. So we wanted to know if this is effective or not. That's the main reason behind. Very recently, in 2021, they implemented another program where health workers on motorbikes, they were reaching the extremely isolated. We don't have the variation, but ideally, I mean, we have a constraint in terms of data. In an ideal world, we will know how many children get vaccinated in each permanent transit point and when. This is part of why combining policy makers and researchers is important. But yes, that's the main reason. And why polio? So there's no reason. So in this case, it was the crisis in Pakistan, and polio has been claimed by the World Health Organization that it probably is the next or the second human disease to be eradicated, right? So a decade ago, we were close to be eradicated, and that was the main motivation behind of wondering why we haven't reached that point, right? After smallpox, this in principle should be the second one. Yeah, that was the reason behind. Thank you. Thank you very much. Perhaps join me in a round of applause for all of our presenters today. Thank you. In the interest of time, we are taking the shortest break imaginable. I'm asking you to get up from your seats, get a cup of coffee if you need it, and sit back down with your coffee. And then we will switch to the next panel in the next 3 minutes, 5 minutes, 5 minutes. And to those of you online, please join us back here in 5 minutes. Thank you.